competing with the legends next door. Inshallah, I'll try to entertain you. So I'm very happy that I've been asked, actually, to speak on a subject which I've spent, I suppose, my life almost to try to study. So I hope I'll give you some insights into diabetic neuropathy. Okay. So these are my disclosures. And I must say, I know this is a company-sponsored Nabi Qasim. Even honestly, this is completely independent. They haven't even looked at my slides. So whatever I'm going to take to you is what I feel, right? It has no product-related, I would say, endorsement as such. So, what is diabetic neuropathy? Well, diabetic neuropathy is, of course, pathology of the peripheral nerves and is a dying back damage, and it affects 50 to 90% at least of people with diabetes. What are the consequences? Well, we used to say it's around 20%. 1 in 5 people will get painful neuropathy. But it is clear that if you do studies in this region, and I've done studies in the Gulf region, in the Middle East, it is actually close to 40%. So it is a highly prevalent complication of nerve damage. And of course, we know that a proportion of people also develop foot ulcers. And as a consequence of developing foot ulcers, you have this complication, which is ulceration, infection, combined with vascular disease leads to amputation. And that's ultimately what we're trying to prevent. So the key approach to preventing these complications, I believe, is earlier detection and treatment of the risk factors. And I'll talk through those. So when my title was Cinderella complication. Why is it the Cinderella complication? Well, it's the Cinderella complication, diabetic neuropathy, because for diabetic retinopathy, we have relatively easy tests to identify not only advanced disease, but early disease. For nephropathy, we have microalbuminuria, we have EGFR, easy to identify. However, for neuropathy, unfortunately, we rely very heavily still on techniques which are, I think, outdated and old, but it requires a neurological examination. And I can tell you, most people in primary or secondary care don't have the time to even take the shoes and socks off. So never mind doing a neurological examination or assessing the monofilament. So I believe that we need to change that, the way we approach this. And something's happened to my slides. But anyway, so we end up with late diagnosis. So again, recently we did a review of what this underdiagnosis is, right? So we did a study in Qatar where we showed that 80% of people in secondary and primary care were not being diagnosed with neuropathy. And I thought, that's terrible. Maybe it's just a problem that we have in the Middle East. But actually, it's not a problem in the Middle East. You can see here, Malaysia. Do you have a pointer? Do you have a pointer? You can see not diagnosed, 90%, 79%, even USA, 79%. Qatar, we had 82%. So across the world, there is an underdiagnosis of particularly painful diabetic neuropathy. Why? Partly because we don't have time to do it, but secondly, actually, it is because fundamentally, we have an issue with the tests that we use to assess neuropathy. So what are the tests? Well, the monofilament, for example, or vibration perception, or nerve conduction, which group of fibers does this focus on? Anybody know? Is it the large fibers or the small fibers? Thank you. So these are the tests. So is it the large or the small fibers? It's actually the large fibers. However, we completely ignore these small fibers, and which are the earliest fibers to be damaged? It's the small fibers, right? So this small fiber damage actually occurs about maybe even 10, 15 years before large fiber damage. But most of the tests that we use in clinical practice are actually focused on looking at the large fibers. And we need to have techniques, I think, that will allow us to identify this early small fiber damage. Now, the only current gold standard technique that we have is actually skin biopsy. So who's volunteering for a skin biopsy? Anybody? Anybody? No? Okay. So, and that's the problem. We don't have a easily, I would say, usable technique. And that's where actually I know if you've been to my lectures, you've heard of corneal confocal microscopy, but this, honestly, I believe is the way forward. So what is corneal confocal microscopy? Corneal confocal microscopy is actually an ophthalmic test. It allows us to look at the nerves in the cornea without having to take a piece of tissue out. The camera just touches the front of the cornea, and because of that, we can actually image nerve fibers. And by magic, it allows us to look inside the cornea and look at the nerve fibers. And so, essentially, what we've done is studies over, I started when I was still a young man. I didn't have a beard then. I certainly didn't have a white beard. And we did some studies in Manchester where we showed that if you look at these nerve fibers, and these white lines are nerve fibers in the cornea, you see this is a patient with established diabetic neuropathy. And you can see less nerve fibers. And if you count them, you can see there's a progressive loss of nerve fibers. So this paper you can see was published in 2003. And now it is 2024, 21 years ago. And honestly, I can tell you that, and I put this video up because what I've had to do for 20 years is fight against, I would say, what most people believe, that this technique can't measure diabetic nerve damage. You get the gist. So there are good guys and there are bad guys. I think I'm a good guy. So basically, I've had to battle against the bad guys to try to prove that this technique, corneal confocal microscopy, is better than these techniques. And we now have multiple studies, over 4,000 patients, 38 studies, which all show the same message, which is that corneal confocal microscopy can detect nerve damage in people with established neuropathy, but also with subclinical diabetic neuropathy. And furthermore, we've looked at people with painful diabetic neuropathy. Now, if you agree with what I say, you would say that if small fibers are damaged and they cause pain, then there should be more small fiber damage in people with painful diabetic neuropathy. And we've now done multiple studies showing exactly this. So this is painful diabetic neuropathy, this is painless diabetic neuropathy, this is controls. What you see is less nerve fibers in painful, all four parameters, compared to healthy controls, and lower than painless neuropathy. Furthermore, we've shown that if you have more pain, severe pain, you have less nerve fibers compared to people with mild pain. So we have an objective test that allows us to identify nerve damage early and identify people with painful neuropathy. So we have to change, I believe, the paradigm for diagnosing diabetic neuropathy. This is how we currently diagnose diabetic neuropathy. When symptoms and signs are present, when people already have foot ulcers, to me, it's useless showing that monofilament is abnormal at this stage. What we need to be doing is actually looking at the disease at an early stage. So all of these have to disappear, and we have to replace it with something. And I would say that that something should be corneal confocal microscopy. So is there anything we can do for diabetic neuropathy? Or do we just use a corneal confocal microscope, diagnose it, and then, as with most neurological diseases, commiserate with the patient? Say, I'm sorry, you've got diabetic neuropathy. Thank you. So there are things that we can do, and there are two aspects. One is that we can treat the pain. Okay? How do we treat the pain currently? Well, there are a number of medications that we, of course, use to try to treat the pain. These medications work at different levels of the nervous system: periphery, spinal cord, or brain. So if we look at the periphery, we know that you have damage to the peripheral nerves. The drugs that work at the periphery include capsaicin, even local anesthetics, there is a patch. Anti-inflammatories work at the periphery. If you look at the spinal cord level, there are a number of drugs, and with this includes the gabapentinoids, the tricyclics, tramadol, opioids. So these all work really on the ascending pathways. And then we have drugs that work either on the brain or what we call the descending inhibitory pathways. And this is the SNRIs, tricyclics, tramadol, opioids. They all work on descending modulation. And what is descending modulation? Well, essentially, if you have a lesion that is causing pain here, pain signals pass up here and go up here. If you have a good inhibitory pathway, descending modulation, then it blocks the pain here and therefore reduces pain felt by the patient. And if you want to look for guidelines, the last guidelines that were done were 2015, but I can tell you I've just actually come from a meeting with one of the authors from the new 2025 guidelines, which aren't even out yet, and they haven't changed, right? And essentially, this is what will be even the new guidelines, which is once you have a patient with diabetic neuropathic pain, you have first-line therapies, you have second-line therapies. First-line therapies still remain the anticonvulsants, which is gabapentin, pregabalin, mirogabalin, SNRIs, duloxetine, and the tricyclic antidepressants. So all three. There is now a move towards avoiding opioid analgesics, and if you don't get an effect with one, for example, anticonvulsants, try the SNRIs. If not, you can also now combine first-line therapies. So low dose of anticonvulsant with a low dose of SNRI. And that is where we're at the moment. So does anybody know when say, pregabalin was approved? Does anybody know? How long ago? The FDA approved it in 2004, 20 years ago, okay? And there has been no new drug that has come out since then. Both duloxetine and pregabalin were approved actually in 2024. So, how good do they work? So this is actually a trial that was done, just published in the Lancet 2 years ago, called the Option DM study. And basically, the Option DM study compared the 3 first-line drugs. So these are the first-line drugs. It was pregabalin, duloxetine, or amitriptyline. And what did they show? Basically, no difference between either amitriptyline, pregabalin, or duloxetine. They all worked about the same. And they all worked not very well, actually. If you looked at the amount of pain relief that was achieved, it was only about 50%. So there is something that intrinsically, there is a problem. And part of that problem actually is that if we increase the dose to the high levels, people get side effects. And so we now have to have a way of, I would say, getting cleverer in terms of identifying the patients. This is called personalized medicine, that will respond better or best, say, to duloxetine or to pregabalin or to gabapentin. So how do we do that? How can we personalize the management of painful diabetic neuropathy? How do we know that this man or this woman is going to respond to duloxetine as opposed to, say, pregabalin? So now actually there are approaches around, and I'll share them with you. So one of the approaches is to look at the patient. So this is a study actually that was done from Scandinavia. So they had a clinical trial where they looked at oxcarbazepine. Oxcarbazepine, you will know, is a son or daughter of carbamazepine. And we all know carbamazepine actually works really quite well, right, in some patients. So it was a trial that was done, failed, right? It didn't work. The drug, they compared it to placebo, hardly any effect, right? It was comparable to placebo. So then what they did is they took the patients and they said, okay, we're going to look at these patients and we're going to do some special testing to assess whether the patient has something called an irritable nociceptor or a non-irritable nociceptor. Now, what does that mean? Essentially, it means that if I was to stroke my hand like that, I would feel irritable. So I would feel painful. So that's an irritable nociceptor. Whereas if I do that and I don't, that's a non-irritable nociceptor. So then this is what they did, and they actually did a number of tests to identify irritable from non-irritable, which was about half of the patients, and they treated them with oxcarbazepine. And what they found is, actually, it didn't work. In those with a non-irritable nociceptor, the NNT was 13. Do you know what that means? An NNT of 13. It means you have to treat 13 patients to get one patient to get a response, which is absolutely terrible. So then they said, okay, what about the irritable nociceptor? Actually, the irritable nociceptor, you can see, did get a response, and this was significant. And here you can see you only had to treat one person, 4 people, to get a response. Suddenly you got a 3-fold increase. And similarly, actually, in Manchester, we've done a study. I'm sorry, but this doesn't project very well. Where we've actually done normally you do EMGs, neurophysiology. And what you do with neurophysiology is actually you stimulate here and you look at how quickly the nerve passes down and produces a response. Now, for this particular study, we looked actually at something called the H reflex. This is where you stimulate distally and you pick up something called a H reflex, right? And if I stimulate very quickly a peripheral nerve, say the tibial nerve, what happens is you get the M wave, you get the H wave. Stimulus 1, you get a big response. Stimulus 2, smaller response. Stimulus 3, even smaller response. And the neurophysiologists have been doing this for a long time, but what they didn't know is that people with pain-less diabetic neuropathy have this good, lesser response, which means the H1 to H3 ratio is actually big. Whereas people with painful diabetic neuropathy, actually, you can see, and particularly those with descending inhibitory pathway abnormalities, actually have a blunted response. So they have a ratio which is equal to 1, whereas this is closer to 0.5. So when you plot this out, what you see is this is your close to 1, which is the painful. These are the controls, these are the painless. And in fact, when we looked at these patients, we found that those who had an RDD, which is rate-dependent depression, which was close to 1, and therefore had descending inhibitory pathway abnormalities, responded to duloxetine beautifully. Whereas those that didn't respond. So that, to me, is the future. Now, the other thing we could do is actually look at genetics. And I must say, I'm not a firm believer that genetics is going to help us, but we have done 2 big studies in Europe called the ProPain study and a Dolos risk study. And essentially what we do show is that there are certain genes called voltage-gated sodium channels, which are found on the peripheral nerve, which actually there are about 20% of people who have variants in these 2 particular genes, which is the NAV 1.7 channel and the NAV 1.9 channel in painful diabetic neuropathy. And there are also other channels as well, actually. And all of these channels are important because this is where the pain starts. If you have an abnormal signaling of these channels, voltage-gated sodium channels and voltage-gated potassium channels and TRP channels, you will get pain. Okay? So now, actually, if you look, there are studies that are beginning to develop, or pharma companies are beginning to develop drugs specifically for these channels. NAV 1.7, 1.8. Do you know where the story started from? Where did they discover these voltage-gated 1.7 and 1.8 channels? Anybody? Made in Pakistan. Is actually from a study that was published in Nature in 2006. And how did they discover these voltage-gated sodium channels? Well, actually, there was a doctor, a geneticist, who was on holiday in Skardul. And he came across a young boy who was actually walking on coals and doing all sorts of kind of amazing things like cutting themselves and no problems, right? And they were getting money for this. And what he discovered is that he had a whole family like this. And when they sequenced the genes, they found that he had a problem with the voltage-gated sodium channels. So if these voltage-gated sodium channels don't work, you get no pain. And this is the condition that they described in 2006. And as a result of that, and we know that carbamazepine actually works on the voltage-gated sodium channels. But it works on a lot of the channels, not just 1.8 or 1.7, which is what you want to target. And now actually there are multiple companies creating small molecule inhibitors for blocking these sodium channels. But sometimes obvious conditions and treatments are the most difficult to grasp. And the one most important one, which I think is relevant to you, which is easy to do for the management of painful diabetic neuropathy, is vitamin D. And this is studies that we've done in Manchester and Sheffield, which show that if you have painful diabetic neuropathy, you have lower levels of vitamin D compared to painless diabetic neuropathy. And again, I actually went, after we'd done these studies, to the MRC, to the Wellcome Trust, to do a trial to show that painful diabetic neuropathy could be treated with vitamin D. And none of them funded it. And then again, made in Pakistan. We did a study actually with the Buckeye, Abdul Basit, and we gave high-dose vitamin D to patients with painful diabetic neuropathy. And actually look at the level of vitamin D, pretty good. And what did we show? A significant reduction in pain, which was as good as gabapentin, as good as pregabalin, as good as duloxetine, without the side effects. So, an improvement in quality of life as well. And now actually, my first go-to, honestly, is I actually check the vitamin D, or even if I don't check it, I give oral vitamin D. The other thing that you may hear about, which I think is coming, is this technique. This is actually, at the moment, very expensive. It's like almost $80,000 to do it, right? But in the patients who've got severe pain, it's actually very, very effective. This is called spinal cord stimulation. And you can see, so this is just by contrast. So this is what happens with duloxetine, with pregabalin. You get this, a score of around 6 comes down to 3. This is what happens with spinal cord stimulation. Literally, you wipe out the pain, and you improve sleep as well. And as a result, you actually get 5% responses in drugs and 80+% responses in patients who are on spinal cord stimulation. And we've actually, so you might say, well, okay, you get rid of pain. Does this benefit the patient? This is actually data we've just analyzed with one of my ex-PhD students, Osman Alam. And what we've done is looked at a big database of about 3,000 patients who've had spinal cord stimulation in the US. And essentially, what we've shown is, this is amazing. MACE, what is MACE? MACE is normally things that you think about in cardiovascular endpoints, right? But this, all the intervention that happened here is pain was reduced, right, with a spinal cord stimulator. And look at this. These numbers you actually see normally in cardiovascular endpoint. 40% reduction in people who had had the spinal cord stimulator in terms of MACE. Mortality, again, 60% reduction in mortality. Amputation, even amputation, and you know, even though pain is being reduced, 80% reduction. And suicide, 70% reduction. So pain, severe pain, actually is really bad for you. And I think if we had therapies like spinal cord, that are as good as spinal cord stimulation, and I believe that some of the new sodium channel blockers will be nearly as good, then we can have a real impact. So, is there anything we can really do for diabetic neuropathy? How much time have I got left, Arshad? 5 minutes, okay. So, what can we do otherwise for diabetic neuropathy? Well, this is a study we did in the Gulf region where we looked at the risk factors for diabetic neuropathy. And what we showed is high sugar, high triglycerides, hypertension, being overweight particularly, being less physically active, and smoking were risk factors for diabetic neuropathy. Okay? So, can we improve neuropathy by treating the glucose? Well, there are data that show that if you give GLP-1, actually, this is liraglutide, you can reduce the risk of amputation. And we've done a study in Qatar where we've compared the once-weekly exenatide and basal bolus insulin, and we've shown, using corneal confocal microscopy, if you improve the blood sugar, go down from 10% down to 7%, then what happens is actually you can repair the nerve fibers. You can see in both groups there is an increase in corneal nerve fibers and peripheral nerves, so there is regeneration of nerves with either basal bolus insulin or exenatide with pioglitazone. What about physical activity? Well, we actually took, again, people who were not physically active and people who were active, which is 30 minutes of walking more than 3 times a week. And we compared corneal nerves over 2 years. What we show is that if you are inactive, physically inactive, you lose nerve fibers over 2 years. So you have less nerve fibers. If, however, you are physically active, your nerve fibers go up. So there is regeneration and repair just by walking 3 times a week for 30 minutes. And we've just in the middle of a study actually with semaglutide once weekly, and we've shown, this is in overweight type 2 diabetics, clearly you lose weight, you improve HbA1c. But we're also showing now that there is an improvement in symptoms of painful neuropathy, and there is actually a repair of nerves. So this is nerve fiber density, it's gone up, just with 6 months of treatment with semaglutide. And we've just done a study with actually an SGLT2 inhibitor. This is a study we've done in India, where type 2 diabetic patients either received 10 milligrams of dapagliflozin or just standard of care. And you can see the HbA1c came down by 0.53 and 0.57%. But look what happened to the nerves. In the dapagliflozin arm, there was a significant increase after 6 months of 3 different measures of corneal nerves. So there's regeneration of nerves with an SGLT2 inhibitor. ACE inhibitors, this is actually one of my old papers, but we showed many years ago, too long to remember, 1998, that if you take diabetic patients who actually have normal blood pressure, no microalbuminuria, and you give them an ACE inhibitor, you can actually improve their nerve function. So nerve conduction, M wave amplitude, and F wave latency all improved significantly. Lipids, there are statins, of course, we use, but there are data that show that triglycerides are actually the most important, right? And this is a study from Australia which shows the effects of omega-3 on diabetic neuropathy in patients with type 1 diabetes. What did they show? They showed actually that within 180 days, omega-3 improved significantly corneal nerves, again, nerve branch density and nerve fiber length. The last drug, which we again don't use enough, is fenofibrate. So fenofibrate is a drug normally traditionally used for lowering triglycerides, but there is this study, which was published in The Lancet, that showed that actually you could reduce the risk, where I started, I'll finish, the risk of this amputation, minor, not major, but minor amputation you could reduce if you're on fenofibrate. And this was published in 2008, 2009, and we didn't really know what the mechanism was. Was it because of an improvement in the vasculature? Was it because of an improvement in neuropathy? So now actually there is a study that's been done from Singapore in 30 patients with type 2 diabetes who received fenofibrate only for 30 days. And what did they show? Well, they showed that there is a reduction in triglycerides, but there is actually a repair of nerves. So there was an increase in corneal nerve fiber density, literally within 30 days of treatment with fenofibrate. Thank you. I finish. Happy to take questions.
Thank you very much, Dr. Rayaz Malik. Such a fascinating lecture. Neuropathy, when you start reading it, is so boring, but you made it so interesting that, I think all of them really enjoyed it. So I think we have some time for very few quick questions, if any of the audience has any questions.
I am Dr. Arshad Humayun, family physician from Lahore, Kent. And thank you very much, Dr. Rayaz and Malik, for highlighting the diabetic neuropathy. Sir, you have mentioned this gabapentin, duloxetine. Both have the different, mechanism of action. Do you think duloxetine is better than pregabalin in reducing the pain?
No, and the evidence speaks for that. So the option DM study, which is probably the best study to date, shows they are all pretty equal.
And what is the pathophysiology of diabetic painful neuropathy?
It's actually, if you look, and we did this exactly the same as diabetic neuropathy. So we actually, in the same paper, where we looked at the risk factors: poor sugar control, hypertension, hyperlipidemia, being overweight, less physical activity, smoking, exactly the same.
And this reduction in diabetic neuropathy, you said that fenofibrate and GLP-1 analog, they help.
Yes.
What is the mechanism? Is it the reduction in the glucose level, which
No.
is beneficial, or something else?
It's actually additional. So there are data that show that for GLP-1, there are actually receptors on the nerves themselves, GLP-1 receptors. And there's like about 100 papers now that show that they have a direct effect on nerves. And there are ongoing trials currently, I can tell you, in dementia, in Parkinson's disease, with GLP-1 receptor agonists, showing improvement. For dapagliflozin, I hope my data showed that we had a comparator arm where we had other drugs, not SGLT2 inhibitors, other drugs that were causing a reduction in HbA1c, but yet it was in the dapagliflozin arm that there was an improvement. So there again, we need to now work out the mechanism. We've literally just done this data.
And any study regarding the use of B12 in prevention?
Yes. So there is a study from Greece that shows that if you have people not even with deficient B12, if you give B12 1,000 micrograms a day, over 12 months there is an improvement in symptoms, there is an improvement in nerve conduction, and an improvement in quantitative sensory testing. So there is benefit.
Sir, in peripheral diabetic neuropathy, what do you think? It is
Sir,
the
can we-
reduction effect on the nerves, or
Sir, please,
reduction in the blood flow?
B12?
Reduction in the blood flow
Oh.
at the peripheral level,
Yeah.
or some effects on the nerves which is causing the problem, which is the major
Well,
effect.
I think
John.
blood flow is important.
Both,
Yeah. I
both.
mean, ACE inhibitors, we showed this 20 years ago, that there is an improvement in neuropathy.
And what's the role of oxidative stress in that?
Oxidative stress, it sounds good and everybody talks about it, but the reality is, for me, the simple message to you is, if your patient isn't on an ACE inhibitor, they should be on it. Fenofibrate, SGLT2 inhibitor, a GLP-1, all of these drugs benefit.
Thank you.
There aren't really any very good antioxidants around. Thank you.
Assalamu alaikum, sir. Sir, I am Dr. Mohammed Naeem
Please
Afzal.
keep
So I'm
it to
here-
one question,
Yeah,
please.
I will be on. Sir, I'm working as professor of medicine at Fatma Medical University. I want to take your attention to a study that we are going to present tomorrow that is related to today's topic. That we did a cross-sectional study and we divided the patients with no neuropathy and normal hand grip strength, and patient with neuropathy only, and patient with neuropathy plus reduced hand grip strength. And we found a significant sharp decline in patients with dynapenia and neuropathy when they were combined. So I want to have your attention and the whole attention of the audience as well, that dynapenia is becoming quite prevalent in our society, and that is happening at a younger age. And addition of dynapenia and neuropathy, they are combiningly exerting a lot of sharp decline in quality of life, and we must focus on this aspect as well.
Okay.
Thank you, sir.
Assalamu alaikum. I'm Dr. Sumaira. I'm an endocrinologist from Indus Hospital, Karachi. So you've showed some good results on Phenoget. Most of our patients are diabetic, already on statins. So putting them on Phenoget, how do we adjust Phenoget along with statins? Considering that you're getting the advantage of Phenoget for the diabetic neuropathy. How do we adjust?
Yeah, so actually, number one, they don't have to have hypertriglyceridemia to benefit from fenofibrate. And you don't have to adjust because, they're on a statin to lower LDL, right?
Yeah.
So this additional benefit that you're going to get from a fibrate is going to be that the HDL will be slightly increased. And you do know that in people who go on statins, actually, the HDL actually drops a little bit. Right, so this is going to be benefit, and the triglycerides are going to come down. That's the key target.
But the combination causing myopathies, people discourage.
No,
So-
that's old. That used to be the bezafibrate and statins
Okay.
that used to do that. You should, or gemfibrozil, I think they used to. Fenofibrate is perfectly safe with statins.
Thank you.
My name is Nasrum Iqbal. I have a quick question. Have you tried alpha lipoic acid? Because there were some studies on it helps diabetic polyneuropathy and zinc.
So alpha lipoic acid has been marketed very well. That's all I have to say. If you look at the evidence, it's actually really isn't very good. And the FDA have never approved alpha lipoic acid. I know there are people who market alpha lipoic acid, and what I would say to you is it has no side effects. So it kind of, people use it, but honestly the evidence is very limited.
Excellent talk. I am attending your neuropathy lectures for last 12 years. My question is there any new drugs approved after duloxetine and pregabalin?
Yeah, so there are these new sodium channel blockers and TRP1A antagonists. So there are drugs coming along, but honestly, I've just been to a meeting of specialists in this area, and they were all crying because for the last 30 years, we haven't had any new drugs. So, yeah. Vitamin D.
Sir, thank you very much.
Thank you for the
Dr.
questions.
Rayaz Malik.